you this. I'm just going to get over on this side this time and see if I can get out of the way and get a little bit closer to the side area, since I unfortunately put some of the writing in white and it's hard for me to read. But we're going to talk about upper airway stimulation therapy. How many of you have worked with any of this today? Anybody? All new? Okay, one, two. Anybody else? Okay, I have some. All right, good. Well, this will be kind of a new project for everybody, so this is good. I have no conflict of interest. And so what we're going to talk about here, what is it? What is this implant device? The upper airway stimulation therapy is an implant, and it is an implantable nerve stimulator. It comes in three parts that gets implanted. The nerve stimulator itself, the small package, and then it has a respiratory sensor, and then it has a stimulation lead. And so those are the three components that are implanted into the individual. And then the external parts are the physician has a remote control and the patient has a remote control. The physician has a remote control so that when they come in for office visits, he or she can make those adjustments there. That they have, and then the patient turns it on and off before they go to turns it on before they go to sleep. But you can see a little bit better on this one. The neural stimulator is here, and then I'm going to jump ahead. It's in a small pocket that is below the clavicle here, usually on the right hand side. And then the respiratory lead goes down to the respiratory sensor goes down to the fourth intercostal region, which is measuring, what you're needing for respiration typically. And then the nerve stimulator comes up and tags into the hypoglossal nerve. And basically, it's a sense of tunneling your way to better sleep, because what they do is when they implant the nerve stimulator in the small pocket below the clavicle, they tunnel the rest of those leads into their appropriate places and get them to the fourth intercostal and then up into the hypoglossal nerve area. And that nerve area, when it's triggered, it stimulates the genioglossus muscle during inspiration, and that's another key thing. It is when it stimulates the nerve, the hypoglossal nerve, and then it stimulates the genioglossus muscle. Then what's doing is it's contracting the lower section of the tongue. Think of it as an internal tongue depressor. Now, if you can simulate that for just a minute, it's kind of interesting, just a concept of it. I can't make this out. All right, so you basically are wanting to do this during inspiration. So start to initiate an inspiration right now. Now imagine getting just a small nerve stimulus right here, okay? And imagine that your tongue is like doing a small, I'm not making fun of this, I'm just trying to describe it to you. I know it sounds like that, I'm not really doing that, all right? I just want you to kind of get the effect of what is happening to the tongue when it gets the stimulation effect, okay? So it is contracting, and it's, as I mentioned, like an internal tongue depressor. And it does tend to work, okay? Because, as we'll see here in just a minute, they've got pretty good numbers for it. The eligibility requirements, if you're talking to the Mayo Clinic, the eligibility requirements are you have to be 22 years of age and over. You have to have moderate to severe OSA, which moderate to severe we know is 15 to as much as say 65 on the AHI. And the body mass index needs to be below 33 kilograms, basically. They have to have some difficulty adhering to CPAP. There has to be, an element that they tried it, didn't work for them, they weren't comfortable with it, they just couldn't keep it on. And there's no significant comorbidities. So when we're talking no significant comorbidities, we're talking neuromuscular disease, hypoglossal nerve palsy, severe cardiopulmonary disease, active psychiatric disease. I'm sorry. I just had to think about that for just a minute because you think about this in psychiatric disease, that would be extremely difficult. So we really want to screen those persons individually and properly. Also, they would not need to have any pronounced upper airway abnormalities like class 3 to 4 tonsillar hypertrophy. So we'll make sure that's not it. And then any anterior posterior predominant retropalatal collapse on drug-induced sleep endoscopy. So in other words, if they're being put to sleep, you want to make sure that they're not having any kind of retropalatal collapse during that period of time as well. They had a STAR trial for nerve stimulation in order to determine this and who would be qualified for these this type of implant device. And so the pivotal study of the hypoglossal nerve stimulation was what's called the STAR, or the Stimulation Therapy for Apnea Reduction. And that came out and was published in New England Journal of Medicine in 2014. So this has been going on for quite some time. It's new sort of to us, but at the same time, the studies have been going on for quite a while. And the trial included about 126 patients with OSA who had difficulty initiating and maintaining continuous positive airway pressure. The stimulator was noted that they had a 68% reduction in the apnea-hypopnea index. That's notable. That's very notable. 68% is great. So it went from let's say an AHI of 29.3 events an hour down to 9 events an hour over 12 months. Okay. Now, 66% of the subjects achieved a reduction of at least 50% in an AHI of less than 20 events per hour. Now, just process this for just a little bit and keep going. Okay. The AHI reduction was accompanied by improvements in daytime sleepiness and functional outcomes of sleep. So they did show effective resolution to the issue. All right. And the rate of serious adverse effects during the study was less than 2%. So 2% of 126, that's like 2.5 persons had a significant adverse effect. Now, we're going to talk the contraindications for putting this implant in. I just kind of want to break this out. I'm running through it not fast because I'm just painting the picture of what the implant device is, how it works, who is selected for it, and then how it's designed to innervate the genioglossus muscle in order for the airway to open. And it's only going to open upon inspiration. That's a pivotal thing. So we need to keep that part in mind, especially when we start looking at what the contraindications are. Right? Okay. So the therapy is currently not considered appropriate for patients with mild OSA, children, patients with a body mass index greater than 33, or patients who are successfully using CPAP or are just curious about doing something different for change. This first one here, central and mixed apnea, is greater than 25% of the total AHI. This is imperative that you as a sleep technologist know this. If you're doing Inspire patients and you're doing the monitoring, the PSG testing for these individuals, you have to know the difference between your scoring of obstructive sleep apnea and central sleep apnea, because with these individuals, if you get it wrong and they have a permanent implant device, I don't think it's been a therapeutic endeavor, right? So if 25% of their overall AHI was scored as central or mixed apneas, they are not a candidate for the Inspire implant device, right? Because they have to be able to do that. If they can't do that, then it doesn't know the trigger to be able to move the tongue out of the way so that they can open the airway, right? So that's an imperative. We did a study not too long ago in our lab for an individual that was supposed to be and was scheduled for an Inspire implant device. And as it turned out, they had predominantly central sleep apnea. They were cardiac. As we know, cardiac patients tend to have a higher incidence of central apnea. device. There are some limited number of MRI procedures that can be done, but the radiology department really seriously needs to evaluate that and make sure that their protocols match up with what the device protocols require. Otherwise, as we know, significant damage can occur. So patients who are unable to or do not have the necessary assistance to operate the sleep provider. All right, let's process that for a minute. Let's say, Cassie, you gave us your age a while ago, so I'm going to play with you here for just a minute to say you're what now, 25? Okay, let's say Cassie needed an Inspire device, and she's going to be able to use this for most of her life. All right, what happens and how does this process? And these are only questions that I have. I only have to ask myself these things because it's my job as a director and as a risk manager within my facility to know what if this, what if that, what if the other, and that's going to I'm going to write policies. All right. So what if Cassie gets to my age, which is mid-60s, and our previous lecture was on Alzheimer's, and for some reason that kicks in. Is she able now to manage her own implant? Now these are the what ifs that I'm just asking. Okay, I'm not advocating pro or con. It's just things to think about. Right? The side effects of the implant device. All right, so I'm going to sound like a little bit of a commercial when they give you the medication that they're promoting, and then they give you all the side effects because by law they have to tell you those. So the side effects, just potential, doesn't mean everybody has these, it's just potential side effect. Excessive bleeding, damage to the nerve, infection, allergic reaction, rejection of the implant materials, persistent pain in that site, discomfort from stimulation, tongue soreness or weakness, tongue movement restrictions, difficulty swallowing or speaking, scarring or fibrosis around the implant, dry mouth, insomnia, other acute symptoms such as headache, coughing, choking, etc. Okay, so there's a few to consider. Of course, with any surgical implant, that could be the case. So, again, in all fairness to the company and in fairness to the device, we want to say that as a caveat, that could be if you had a tonsillectomy, you can pretty much say the same thing. Okay. All right. So the warnings, and these warnings come from the Inspire manual directly. All right. These are from the manual. Medical procedures, you want to avoid diathermy. And I talked to a couple of physical therapy friends, and they told me I was still in the 40s. So when you're talking diathermy, they don't tend to use it that much, but it has to be listed in the medical manual for the Inspire device. And diathermy is anytime you're using a heat or electrical source that is or sound or electricity that's going to do deep muscle heat on any location in your body because it has a potential then to damage the Inspire unit. So that's rather pertinent information. If you're doing an MRI, we've already talked about that. You don't want to have to just roll in there and not mention to anybody about an Inspire implant device. Just like if you have any other implant device, you have to let the radiologist know that you've got something within your system that might have some bearing on how that MRI is going to work. Right? And by the way, even if they take the stimulator out and they tend to leave the leads, is my understanding, you still have to let them know on the MRI that that's going on. Radio frequency, microwave ablation, electrocautery, all of these things can damage the internal workings of the machine. Defibrillation, cardioversion, obviously we know that's going to be very close to where the implant device is. Life is going to matter over function of an implant device, but after all this said and done, obviously you're going to have to reevaluate the implant device and whether or not that's still functioning the way it was designed. Again, from the Inspire patient manual, these medical procedures can cause permanent damage to the stimulator, particularly if used in close proximity to the device. Dental drills, ultrasonic probes, electrolysis, bone growth stimulators, laser procedures, psychotherapeutic procedures, and unfortunately that's called electroshock therapy. Some radiation therapy will also cause damage to it, so we have to be mindful of all this. High output electronics such as lithotripsy. You don't want to start breaking up kidney stones right away without consulting the doctor on that and make sure everything's okay. Again, warnings continue on this. The electromagnetic interference, we can only say there, with any electronic device, I learned this the hard way when I was trying to jumpstart my battery one day when I was about 16. If you don't cross those things up just right, it will cause electric arc. You guys got me out here, you guys know what I'm talking about there now. It will totally fry your alternator. Did y'all know that? Yeah. I did that too. All right, so the things that would cause electromagnetic interference on an everyday basis that people might not be aware of, who may not have, had the opportunity to read some of this. Antennas of a citizen band or CB radio, ham radio, electric arc welding equipment, that's kind of where my stuff came in. The electric induction heaters, steel furnaces, high power amateur transmitters, high voltage areas. High voltage areas are like walking under the power lines for TVA. So, I mean, if you have an employee or you have a patient that comes in who's an employee of TVA, who is a lineman, is he a good candidate? Okay, these are the things we just want to think about. Okay, let's process, because if the doctor didn't hear about it during, the initial visit to consult, if they're coming for their initial pulsonogram and you pick up on a lot more information than the doctor does in that 10 or 15-minute consultation session that they sometimes get with their patients. So we know we get a ton more information. We need to be willing to process that information. Hey, by the way, anybody knows that he's a lineman? That's what he does for a living? And we're talking high voltage. Do we really want to do this? I mean, is there another option that we might consider for him instead? So I'm just saying, these are the things just to put into your mind to say, all right, I'm not working with this today, but wait, they said something about such and such, and just pull it back up and read it. All right, Google it. It's there. It's everywhere. Right. So television and radio can sometimes cause a little bit of problems with these. It depends. Of course, I can imagine tornadoes can too, because you're never going off here in this building. If you think about it, a tornado runs. A tornado runs at about, 55, 58 frequency, okay, so 55 hertz. So in the old televisions, you could turn your television station to channel 2, which is on the same frequency way back then. And if there was a tornado within, say, 10 to 12 miles, it would light up, all right? I'm just saying. So if it will light up the television screen, what will it do to the nerve stimulator? Just a question, okay? I'm just curious. All right, so enough of that. I'm really seriously looking at this, okay? I'm evaluating, because I actually have someone here who has someone who has had the Inspire put in. And so, there were some questions about that when it first happened. So these are all questions that we have to ponder and go, I wonder what would happen if. Yeah, you can have a lot of fun with some of that. The cost for the device currently, on the very last thing that I pulled up, was $20,000 for the device. The replacement battery can cost up to $17,000. Okay, and that doesn't include the cost of the surgical procedure, by the way. Okay, doesn't include the future cost for education and assessment of it. So it's not a one-stop shop and you get it all at one time. It's broken down over a period of time, and the surgical cost is separate to it. It does cover Humana, Cigna, Kaiser, Blue Cross Advantage, Bluefield. And just today, I'm at initial one for the diagnosis. We're going to do the CPAP PSG initially to be able to try and see if they can be compliant to that. And then the post-op PSG to fine-tune the settings once they've had the Inspire placed in there. And then future PSGs to make sure everything is working as it needs to go. So is this going to take away from our business? No, not in that respect, no. We will not necessarily get repeat CPAP business out of it, or we will be getting, those studies out of an individual as they need, and their needs change and progress as well. Now, I told Jeff earlier today when we were talking outside that I was going to be delivering pros and cons of the device, okay? The pros are, speak for themselves. If you got 68%, and by the way, he said 80%, but they have an 80% improvement right now. So I could adjust my numbers to say 80%. But the pros and cons that I want to show you are coming from patients who've actually had an implant done. So we're going to go through. Can anybody read this? Can you read it? Okay, good. This is July 17th, 2019. This is from a patient out of Sleep Review magazine that reported this. I found this method of fight sleep apnea useless. I think the device is not ready to be used on the general public. I had the implant for several years, and it's unusable. Removing it is my only option. CPAP is the only real treatment. Okay, so we have a con. And then again, in July 2019, I had the Inspire implant on June 17th, and this past Monday, after healing from the surgery, they turned it on. I've had a great outcome, sleeping much better. My husband's back in her bed after years of very loud snoring. Yes, it's a little discomforting in my throat, but it feels better and better every morning. So we have pros. And then we have this gentleman. June 4th, 2021. I'm trying to get the most current stuff as much as I could to get patient reviews on all of this. And this one is rather lengthy. So this is after 30 months of Inspire use. I've also found a patient manual on the internet, which I now wish I'd seen before having the surgery, which states that stimulation can initiate if you are your CD radio, other electrical devices, dental grills, or their induction stovetop. And we did just talk about it. It came from the actual Inspire manual, so he just has discovered this. All right, this is not so bad for me because I had an excuse to not help my wife in the kitchen. But bad news for not being able to use the headlight. He had two-way CD radios that I use hiking with the welder in my shop. I also need to remember to take the control with me when I go to the dentist. He said, I also noticed that it will not work at all if my electric blanket is turned on. I sure hope he doesn't live in the house. And I noticed that sometimes my electric shaver will turn on the stimulation. Experiencing this makes me want to carry the remote with me everywhere in case the system turns on. That's a legitimate problem. I mean, it's just, you don't know what's going to trigger these sorts of things. Okay. In summary, this is from the show still. In summary, the Inspire unit is a tremendous implementation of the treating concept. I would not recommend it to anyone. And now note that this patient is now using low pressure BiPAP in conjunction with his Inspire. Okay. So it wasn't taken out, it wasn't removed. He still has it. He's still using it to a degree, but in conjunction. So in summary, the upper airway stimulation therapy appears successful in reducing the HI by 50 to 68% in most patients. The cost of surgery and the device is covered by most insurances as well as Medicare. Replacement batteries at $17,000 was not mentioned in the provider coverage. Sleep studies are essential for diagnosing and assessment of the UAST, and side effects are significant on several facets and bear proper consideration prior to surgery. So when you're giving informed consent and you're doing this, you need to be able to know exactly what some of the side effects are, what some of the triggers are for that stimulation device, what type of employment your patient may or may not have, and what is the cognitive level of your patient, and what is the physical ability of the patient in order to protect the patient going forward. Now, it's one thing if we put the device in today, and tomorrow they have a motor vehicle accident, and now they're a head trauma. Okay, I'm just saying that that's an extreme case, and it's just something that we have to consider all of the what ifs and make informed decisions and give informed consent as you go forward, educating the patients and taking care of their specific needs. Do we have any questions?
So if somebody has this implant, what are the chances of them saying it doesn't work out of my
I missed the last part. I got.
What if they choose not to use the Inspire? What are the chances, likelihood of insurance then going back and paying for therapy? Will they still do that or not?
It's my understanding that they would still pay for their bypass CPAP ASV as needed. It is not working for you. Just as you medically proved the CPAP wasn't working for you and you went and got the device, now that's going to have to be your fallback plan. Yeah. Any others? Yes,
How
ma'am.
long does the battery last?
Well, that's a perfect question. I didn't see anywhere that was, yeah, I didn't see anywhere how long the battery lasts. What if it's only a year? Well, what if it's a lifetime? I mean, I don't know. I really can't answer that. It's a good question. Yes, ma'am.
Do you see that evolving in a way that a lot of medical devices have as far as, like pacemakers when they first came out, the way things evolve and technology evolves, do you think that will be something that will go forward in a better way?
But it's not going to go away. I think it's going to improve. Certainly, I hope it improves and continues to go on because the initial numbers they have are very promising. I mean, if you're looking at 50 to 68 to 80% of reduction in the AHI on any given individual, it's not going to get them down to zero by any stretch. We all know that. We don't get them down to zero every night when we're running CPAPs and BiPAPs. Ideally, we can get below 5, or if we can get them 75% reduction of their severe AHI, then that's a win for us. So the numbers indicate a win. It's just the side effects that are a little bit problematic right at the moment, but I think that they'll start resolving some of those. Yes, sir.
Why is the BMI at 33?
That seems to be their cutoff. Okay, and again, I can only speculate that it may have something to do with neck circumference and the weight, the gravitational pull, when you're talking about the stimulation lead where it's located in conjunction with the neck circumference. And then that's just speculation on my part. I can't really say specifically.
And he said because it doesn't send enough signal for them to stimulation. So the bigger person, the signal is not going to be strong.
So it's kind of like my extension cord when I went from the house down to the barn. It's only going to go so far, and after I get it to the barn, it's not going to kick off that motorcycle. It's going to dead for the next 2 weeks. Okay. I think I got it. Cassie?
So the patient that had that in the bypass, say they were not compliant to bypass because the pressure was too high. Once they got the stimulator, it didn't work for them as well. And then they put the two together with the pressure be lowered.
Does it make sense?
Tolerable pressure.
Well, yeah, that would make sense if it could be lowered because part of the pressure is overcoming the closure of the airway, right? So if you're stimulating the airway to open and trigger, then the bypass section of the inspiratory section of it would actually work as basically a pressure support and gives you an opportunity to have a higher volume of air intake. So yeah, that makes sense. Good deal. Yes, ma'am.
Being what she just said in your response to that, somebody would that help somebody maybe that, depending on what their situation was, that couldn't tolerate the stimulator well and didn't tolerate the CPAP because they need a full face mask? Would that help them to do a nasal mask better and be more compliant?
Well, now that's a good question. A nasal mask. Well, okay. I'm sorry, I go to different places, but I'm thinking, okay, when they stimulate that, does the mouth come open? And could you put a nasal mask on, or do they have to have a full face mask? I mean, I don't know. I'm just not sure. When it stimulates this, how it would trigger if the jaw is off the mouth. Okay, thank you, Joe Marie, for bringing up who the person was. All right, so now we can talk about it, because now, you're with the client, now we can talk.
I asked him that before I came out here, I said, this comes up.
Yeah,
But he does, he said,
okay,
and he's got the biggest conversation I've ever seen in somebody.
okay,
And he was adamant that he was not wear CPAP. So he had it expired, he had his jaw broken, he got a big chin, and you know what, his AHI is still 35. And it's complex like that.
they make
And
tracheostomy.
he is an intelligent man, he's an architect, very successful architect. And I was like, you're about to do stupid thing.
All right, we won't throw Albert totally under the bus on this one. I already know what so, he's trying, he's really trying, so. But it's in all kinds of things for sleep research and sleep changes and the types of information that we're giving, the research that's being done and the application of it. We fall down here on the application side, but we have to know about the stuff before we can apply. So that's why you come to these events, is so that we can pick up this kind of information, take a look at it, get out the microscope and stare at it a little bit harder and see how it applies where you are and how you practice your sleep medicine. Thank you very much for your time.